She came in on a Tuesday morning, still wearing her coat, and the first thing she said to me was not about pain, not about pressure in her chest, not about the dizzy spell she had mentioned to her daughter the week before. The first thing she said was, "Doctor, I don't know why, but every single morning I wake up and my mouth is completely bone dry. It's been going on for almost a year. My dentist says my teeth are getting worse. I thought it was just part of getting old." Her name was Carol. She was 67 years old, a retired school librarian from outside of Cincinnati, and she had spent 11 months assuming her body was simply wearing down the way bodies do. She was wrong. What Carol had was not aging. What Carol had was a message, a very specific, very detailed message that her body had been sending her every morning at approximately the same hour, and she had been politely ignoring it because nobody had ever told her what it meant. By the time we finished her workup, we had found two things she did not know about. One of them she could manage with a simple medication adjustment. The other one required immediate follow-up care. Both of them had been quietly doing damage while she blamed her age. I am Dr. Pablo. I have spent 18 years as a board-certified geriatrician specializing in cardiovascular and aging-related medicine, and I want to tell you something I tell my patients directly and without softening it. Morning dry mouth in adults over 60 is one of the most consistently underestimated symptoms I see in clinical practice. Not because it is rare, quite the opposite. A landmark analysis published in the journal Oral Diseases found that nearly half of all adults over 65 experience chronic morning dry mouth, which the medical community terms xerostomia. Nearly half. But here is the number buried inside that statistic that nobody ever reads out loud. In more than 80% of those cases, the dry mouth was not the condition. It was the consequence. It was the downstream signal of something else happening in the body, something with real stakes, something that in many cases could be identified and addressed if someone simply connected the dots. That is what we are doing today. Before I walk you through the 5 causes I want to cover with you, I need you to understand something about saliva, because most people dramatically underestimate what it actually does. Your body produces between 1 and 1.5 liters of saliva every single day under normal conditions. Saliva coats the surfaces of your teeth the way a protective film coats a lens. It neutralizes acids in your mouth that would otherwise eat through enamel. It carries digestive enzymes that begin breaking food down before it ever reaches your stomach. It contains antimicrobial compounds that actively suppress bacterial and fungal growth in your oral cavity and your throat. It lubricates the tissues that allow you to speak, swallow, and breathe comfortably. Saliva is, in every clinical sense of the phrase, a frontline defense system. So when you wake up every morning and that system has essentially gone dark overnight, when your tongue is stuck to the roof of your mouth and your lips feel cracked before you have done anything at all, that is not a quirk. That is a gap in your body's armor. And gaps in armor tend to matter more the longer they go unaddressed. Now here is the other thing I want you to hold on to as we go through these causes together. I'm going to tell you up front that the cause I consider most dangerous, the one with the most serious downstream consequences for adults in their 60s and 70s, is not the first one we will cover. I am building toward it deliberately, because I want you to understand the full picture before we get there, and I want you to still be with me when we do. Let us start with the cause that surprises people the most, even though in retrospect it makes complete logical sense. The medication landscape. More than 400 prescription and over-the-counter medications carry dry mouth as a documented side effect. 400. We are talking about entire drug classes that tens of millions of older Americans take every single day without anyone ever mentioning that one of the things these medications do is reduce saliva production. Diuretics, prescribed for blood pressure and fluid retention, actively pull water from your body's tissues, and your salivary glands are no exception. Antihistamines, taken for seasonal allergies by enormous numbers of adults every spring and fall, have an anticholinergic mechanism that directly suppresses glandular secretion, including the glands that produce saliva. Antidepressants, particularly the older tricyclic class, are well documented for this effect. Overactive bladder medications, certain muscle relaxants, common sleep aids sold without a prescription, specific pain relievers, each of these on its own might cause only mild dryness. But here is what the research shows about combination. A study published in Gerontology found that seniors taking 5 or more daily medications experienced nearly double the rate of clinically significant dry mouth compared to those taking 2 or fewer. And the average American over 65 is currently taking between 4 and 5 prescription medications daily, not counting supplements. The arithmetic is not complicated. When I think about this, I think about a man named Thomas, 71 years old, a former electrician who had retired to rural Virginia and taken meticulous care of himself, or so he believed. Thomas had been waking up with severe morning dry mouth for close to 2 years. His dentist had flagged 3 new cavities in the span of 18 months, which was unusual for someone with Thomas's history of good dental hygiene. He had tried every rinse and spray the pharmacy carried. When he came to see me, I asked him to bring every bottle in his house, prescription, supplement, and over-the-counter alike. He brought a bag. Inside that bag were 6 prescription medications, 2 supplements including a high-dose magnesium and a fish oil, an antihistamine he took every night thinking it helped him sleep, and an over-the-counter pain reliever he used several times a week for knee discomfort. When I went through that list systematically, I found 4 separate items with documented saliva-suppressing effects. Not 1, 4. We coordinated with his other prescribing physicians and adjusted the timing of 2 of his medications, not the dosages, just the time of day he took them, to reduce the overlap of their effects during overnight hours. Within a month, Thomas reported that his morning dryness had dropped by what he estimated was 60 to 70%. No new prescriptions, no procedures, just information that nobody had ever put together for him before. If you take more than 2 medications daily, I want you to do one thing this week. Write down every single item, every prescription, every supplement, every over-the-counter product you use with any regularity. Bring that physical list to your pharmacist and ask one specific question. Could the combination of anything on this list be reducing my saliva production? Pharmacists are trained in drug interaction patterns at a level of specificity that often surprises people, and that conversation costs you nothing. Now let us move to the second cause, and this one is where I want you to lean in, because the number of people affected by this who have no idea is staggering. We are talking about obstructive sleep apnea. Here is the basic physiology. When sleep apnea occurs, the soft tissues at the back of the throat relax and collapse during sleep, partially or fully blocking the airway. The brain detects the oxygen drop, sends an emergency signal, and the body startles just enough to reopen the airway. The person almost never wakes up consciously. They have no memory of it. This can happen dozens of times per hour across an entire night, and the person wakes up in the morning feeling like they slept, when in reality, their nervous system spent the night in a cycle of low-level crisis. Here is the dry mouth connection. When the nasal airway is obstructed during these episodes, the body defaults to breathing through the mouth. Mouth breathing across 6, 7, or 8 hours of sleep evaporates saliva at a rate that has no comparison in normal nasal breathing. You wake up and your mouth feels like it was used as a wind tunnel all night, because physiologically, it was. But the dry mouth is genuinely the least of the concerns with sleep apnea. Research from the American Heart Association has established that untreated sleep apnea in adults over 60 significantly elevates the risk of atrial fibrillation, which is an irregular heart rhythm with serious stroke implications, hypertension, and adverse cardiovascular events. A separate longitudinal analysis published in the Journal of Clinical Sleep Medicine followed seniors with undiagnosed moderate to severe sleep apnea over a 5-year period and found measurably accelerated rates of cognitive decline compared to matched controls. So if you are waking up every morning with a dry mouth and the underlying cause is sleep apnea, your mouth is not the story. Your mouth is the table of contents. Ask yourself these questions honestly. Do you snore, or have you been told that you do? Do you wake up feeling unrested even after what should have been a full night of sleep? Do you have headaches in the morning that fade over the course of an hour? Do you find yourself falling asleep in chairs during quiet afternoon moments when you have no particular reason to be tired? Do you sometimes wake with a sense of gasping or needing to catch your breath? Any cluster of these symptoms, alongside chronic morning dry mouth, is a clinical signal that deserves follow-up. And here is something most people do not know. Modern sleep studies no longer require an overnight hospital stay. Home sleep testing devices are worn on the wrist and fingertip, returned by mail, and analyzed remotely. Many Medicare plans cover this fully. A single phone call to your primary care physician to request a referral is the entire barrier. Take a moment right now, if you are finding this useful, and write your age and where in the world you are watching from in the comments below. I read every one of those comments, and knowing who is on the other side of this conversation shapes every video I make. I will pick up from here in part 2, where we are going to cover the blood sugar connection, the hydration deception that catches even careful adults off guard, the autoimmune condition that takes an average of nearly 5 years to diagnose and is dismissed as aging almost every time, and the cause I have been holding back, the one I consider the most dangerous, and the one most likely to be happening silently in someone watching this right now. Stay with me. If you have been with me from the beginning of this conversation, you already understand that morning dry mouth is not a cosmetic complaint. It is a clinical signal. And we have already covered what your medications may be doing to your saliva production overnight, and what obstructive sleep apnea does to your airway, your heart, and your brain while you sleep, believing you are resting. Now I want to take you into territory that I find even more significant, because the causes we are about to discuss involve conditions that are actively progressing in millions of older Americans without a single diagnosis on their chart. Let us talk about blood sugar. According to data from the Centers for Disease Control and Prevention, approximately 38 million Americans currently have diabetes. Pause on this number. Nearly 1 in 4 of them remains undiagnosed. That means roughly 9 million people are walking through their daily lives right now with blood glucose levels high enough to cause measurable organ and tissue damage, and not one of them has been told. Here is the physiological mechanism connecting elevated blood sugar to dry mouth, and it is worth understanding precisely because the chain of events is so specific. When blood glucose levels are chronically elevated, the kidneys work at an accelerated rate to filter the excess sugar out of the bloodstream. To accomplish that filtration efficiently, the kidneys pull fluid from surrounding tissues throughout the body. This creates a state of slow, systemic dehydration that does not feel the way dehydration felt when you were younger, because as we will discuss in a moment, the thirst mechanism in older adults is already compromised. The salivary glands, dependent on adequate fluid availability to maintain their output, reduce production. An NIH-backed analysis found that among individuals with poorly controlled type 2 diabetes, persistent dry mouth was one of the most consistently reported daily symptoms and, critically, had often been present for a year or longer before the diabetes itself was formally diagnosed. That bears repeating. The mouth was warning people 12 months before the diagnosis. The signal was there. Nobody had connected it to anything. I want to be clinically direct with you about additional signs that should accelerate your timeline for getting tested. If your morning dry mouth is accompanied by more frequent urination, particularly waking at night to urinate more than once, if you are experiencing a fatigue that sleep does not resolve, if you have noticed that small cuts or skin wounds are healing more slowly than they once did, if your vision has occasional episodes of blurriness that were not there a few years ago, do not file these away and wait for your next scheduled physical. Call this week and ask for 2 specific tests by name: a fasting glucose test and an HbA1c. The HbA1c is particularly valuable because it gives your physician a 3-month retrospective average of your blood sugar levels, not just what it was on the morning of your blood draw. That test takes less than 5 minutes to complete, and it can surface something your dry mouth has been quietly pointing toward for months. Now I want to address the fourth cause, which is one I have to frame carefully because when I describe it, the instinctive response from many people is to dismiss it immediately. The cause is chronic dehydration, and the reason people dismiss it is that it sounds too simple, too obvious. You think to yourself, I am an adult. I know how to drink water. And you are right that you know how to drink water. But here is what most people do not know about how hydration works in the aging body, and why even conscientious adults over 65 are frequently dehydrated without realizing it. The hypothalamus, the region of the brain responsible for generating the sensation of thirst, undergoes progressive functional decline with age. A study published in the Journal of Physiology demonstrated that older adults can accumulate a fluid deficit equivalent to 2% or more of their body weight without experiencing any meaningful thirst signal. 2% of body weight sounds small until you calculate it. For a 160-pound adult, that is more than 3 pounds of fluid deficit before thirst kicks in. By the time you actually feel thirsty, your body has already been running short for hours. Simultaneously, the kidneys become less efficient at conserving water as we age. The skin loses moisture through evaporation at a higher rate. And if you are already taking a diuretic for blood pressure, as millions of older adults are, your baseline fluid losses are higher than your peers who are not. The compounding effect is a large population of older adults who are quietly, chronically dehydrated through the majority of their waking hours. And the most noticeable outward symptom is that dry, sticky, chalk dust mouth they wake up with every morning, which they attribute to age. I had a patient, a woman named Margaret, 64 years old, a recently retired nurse, which is a detail that matters to this story. Margaret knew more about the human body than most of my patients when she walked through the door. She had spent 31 years in clinical nursing. She tracked her own blood pressure. She took her medications precisely on schedule. She exercised 3 times a week. And she had been waking up every morning for 8 months with a dry mouth that she, with all of her medical knowledge, had filed under the category of getting older. When I reviewed her daily fluid intake with her, the picture became clear very quickly. Margaret was drinking what she estimated was enough water, but she was estimating based on thirst, and she was also consuming 2 cups of coffee each morning and a glass of wine most evenings, both of which accelerate fluid loss. When we actually calculated her net hydration, she was running a meaningful daily deficit without ever feeling it. The intervention was not a prescription, it was a schedule. Margaret began drinking water on a fixed hourly schedule rather than waiting for thirst. She reduced her evening wine to occasional rather than nightly. Within 3 weeks, she described her mornings as entirely different. The fix was not complicated, but without the explanation of why her thirst signal could no longer be trusted, she never would have known the signal had failed. The practical adjustment here is this: stop using thirst as your hydration gauge, because that gauge is no longer calibrated correctly in your body. Aim for a minimum of 6 to 8 glasses of water distributed across your waking hours, and set external reminders to prompt you, because the internal ones will not. Caffeinated beverages and alcohol do not contribute to this total. They withdraw from it. Keep a water bottle visible in every room you spend regular time in, not tucked away where you have to think to reach for it. Now I want to bring you to the 5th cause, and this is the one that I have seen generate the most years of unnecessary suffering without a diagnosis, largely because its symptoms are so effectively explained away by the very doctors who should be catching it. We are talking about Sjogren's syndrome, spelled S-J-O-G-R-E-N, and it is an autoimmune condition in which the immune system mistakenly identifies the body's own moisture-producing glands as foreign threats and attacks them. The primary targets are the salivary glands, which produce saliva, and the lacrimal glands, which produce tears. The result is a body that progressively loses its ability to maintain moisture in the tissues that depend on it most. The mouth becomes persistently dry. The eyes become chronically dry, gritty, and sensitive in a way that eye drops help briefly but do not resolve. Joints develop an aching quality that has no clear mechanical explanation. Fatigue sets in at a level that seems disproportionate to anything the person is actually doing. Now here is the statistical picture that I want every woman over 55 watching this to hear clearly. 90% of Sjogren's diagnoses occur in women. The average age at diagnosis falls between the late 50s and early 60s, and research supported by the Sjogren's Foundation has found that the average patient waits between 2.5 and nearly 5 years from the first appearance of symptoms to receiving a correct diagnosis. The reason the wait is so long is not complicated. Every symptom of Sjogren's syndrome has an alternative, aging-adjacent explanation that makes it easy to dismiss. Dry mouth? That is just getting older. Dry eyes? Everybody's eyes get drier with age. Fatigue? You are in your 60s, of course you get tired. Joint pain? Perfectly normal wear and tear. Each individual symptom sounds unremarkable, but the pattern, the persistent combination of dry mouth and dry eyes and disproportionate fatigue, that pattern has a name, and it responds to management when it is caught. If the combination of symptoms I just described is familiar to you, and particularly if your dry mouth in the morning consistently comes paired with eyes that feel gritty or irritated before you have done anything to irritate them, please bring up Sjogren's syndrome by name at your next clinical appointment. A blood panel screening for ANA antibodies and anti-SSA and anti-SSB markers can indicate autoimmune activity consistent with Sjogren's. It is not an obscure or expensive test, but it is one that very rarely gets ordered unless the patient asks for it by name. Now I want to bring you to the cause I held back, the one I consider the most dangerous in terms of cardiovascular consequence, and the one that connects morning dry mouth to something happening not in your mouth at all, but in the rhythm of your heart. I am talking about the physiological cascade that occurs when the autonomic nervous system, the part of your nervous system that regulates your heart rate, your blood pressure, and your glandular secretion without your conscious input, begins to function in a dysregulated pattern during sleep. In some adults, particularly those with long-standing hypertension or early-stage cardiovascular disease, the normal overnight dip in blood pressure that should occur during deep sleep does not happen. This is called non-dipping nocturnal hypertension, and research published in the European Heart Journal and the Journal of the American College of Cardiology has identified it as an independent risk factor for stroke and cardiac events, significantly more predictive than daytime blood pressure readings alone. The autonomic dysregulation that produces non-dipping nocturnal hypertension also disrupts the glandular secretion patterns that saliva production depends on overnight. The connection is not symbolic, it is mechanistic. And a person waking up every morning with a dry mouth, who also has hypertension that their physician believes is reasonably controlled on medication, may in fact be experiencing blood pressure spikes during the overnight hours that no daytime reading has ever captured. The way this gets evaluated is through ambulatory blood pressure monitoring, a device worn for 24 hours that records blood pressure at regular intervals, including during sleep, giving the physician the overnight picture that a clinic visit never can. If you have hypertension and you have been waking up with a dry mouth every morning, bring this up. Ask your physician whether overnight blood pressure monitoring might be appropriate for you. It is a non-invasive, typically covered test, and what it finds or rules out genuinely matters. Let me now give you something concrete and sequential that you can begin this week. Every morning when you wake up, before anything else, take note of how dry your mouth is on a scale of 1 to 10. Do this for 2 weeks and write it down. Alongside that number, note whether you slept with your mouth open or closed, whether you feel rested or still exhausted, and whether you woke during the night. At the end of 2 weeks, you will have a pattern instead of a vague impression, and a pattern is something you can bring to a physician and be taken seriously. In parallel, Compile your full medication and supplement list this week and take it to your pharmacist for a saliva impact review. Schedule a fasting glucose and HbA1c if you have not had one in the past 12 months. And if your dry eyes alongside dry mouth have been dismissed before, schedule a new appointment and use the words Sjogren's syndrome and ask for the specific blood markers. On the practical side, for immediate relief, look for oral rinses and gels that contain xylitol. Products in this category provide moisture and simultaneously suppress the bacterial overgrowth that dry mouth environments promote. Use them immediately before sleep each night, and critically, avoid any mouthwash that contains alcohol, which will compound the dryness rather than address it. Rinse with plain water first, apply the xylitol product, and do not eat or drink anything after. One clinical note before I close. If your morning dry mouth is accompanied by difficulty swallowing, white patches anywhere inside your mouth, unexplained weight loss, or persistent pain, please do not wait for a routine appointment. These combinations warrant prompt evaluation. I want to close with something I say to patients when they leave my office after a conversation like this one. You came in today not knowing what your symptom meant. You are leaving today knowing that it means something, that it points somewhere, and that the somewhere it points is identifiable and in most cases addressable. That is not a small thing. The adults who do the worst with conditions like the ones we discussed today are not the ones with the most severe cases. They are the ones who waited the longest because they believed that what they were experiencing was simply what aging felt like. You now know otherwise. Take that knowledge somewhere. Make the phone call. Write the list. Ask the question at your next appointment that nobody has asked yet. You have been paying attention to your body for decades. The least your medical care can do is pay attention back. Write your age and where in the world you are watching from in the comments below. I want to know who you are and where you are, because every comment guides what comes next on this channel. If this gave you something real today, share it with someone over 60 who has been writing off their morning dry mouth as nothing. You may do them more good than you realize. I am Dr. Pablo. Take care of yourself this week. You have already done something important by being here.